Thanks very much. Thanks for sticking around for the last session on the last day. I appreciate it very much. And thanks very much to the organizers for the invitation to return and speak to you all once again. Either that means it went okay last time or you thought, give them another chance, something like that. So what we'll be talking about today is a little bit different than what I talked about last year, but I really appreciate the opportunity to talk about it today, and that's the area of medicine that's termed quality improvement. And really, what I was hoping to focus on is the interaction between, or the potential for a positive interaction between parents and medicine through the use of quality improvement. If my voice sounds a little strained, it's because I just came off a week with these campers up in Ohio. So this is our heart camp that we run a little close to Cincinnati, and it is a great time, but my voice ends up suffering after a while. It's mostly the singing and dancing, I think. So as I showed you all last year, and I think many speakers have alluded to this today, what we know is that we've made major strides in mortality around congenital heart disease. And now patient survival is expected. But obviously, we care about more than just mortality. I know all of you in this room care deeply about elements of morbidity and outcomes. That's what the last speaker was just talking about. Thinking about re-interventions, re-operations, pain, suffering around the procedure or after procedures, neurodevelopment, PTSD, anxiety, activity limitations. But even beyond just those measurable outcomes and morbidity, we care about things like the experience of being a heart patient and the family of a heart patient. We care about the experience that surrounds those procedures and the experience of coming to clinic, of making an appointment, of rescheduling an appointment, of seeing a provider more urgently. We care about the relationships that are involved in that experience, that our relationship to the provider, whether it's the patient to the provider or the parent to the provider, or our relationships with each other. And then I think it's also important we talk about value. One of the last speakers talked about in 2009, it cost $5.6 billion to care for patients with congenital heart disease for that year. So the financial constraints are obviously felt. And then the value of those relationships that we make. Well, that's a lot of challenges. So what can you all do as parents to become positive agents of change, to quote Amy Baskin? What opportunities are there as a parent to positively impact not just your own children, but other children? I think most of you in this room are keenly interested in positively impacting the care of your own children, but I would venture a guess that most of you are actually quite interested in positively impacting the care of all children with congenital heart disease. Now, one way you can do that is by having your child participate in research, but obviously it stops a little bit short of your own participation in research unless you've gone the route of getting extra training and modifying your own career, or it just so happened to coincide with your career. So what is it you can do as a parent then to really get in there in the mix of trying to improve the care for kids with congenital heart disease? Well, that's where I think quality improvement offers a really powerful tool, and that's what we'll be focusing the talk today on. So just to give you some background, the Institute of Medicine in a seminal article about quality improvement defined quality improvement as the extent to which healthcare services increase the likelihood of desired health outcomes and are consistent with current professional knowledge. But that's sort of fancy speak for what parents and families really say, which is let's provide better care. Let's improve patient outcomes, and let's improve satisfaction with the care and treatment that we receive. Well, exactly how do we do that? And I would argue that one way that everyone in this room can begin to make those changes is by involving themselves in quality improvement work, because we all, at this point, expect better. So this article that talked about from the Institute of Medicine, it was from 2001. It talked about it was titled Crossing the Quality Chasm, a new health system for the 21st century. And there are really 6 arms from 2001 where they talked about as we move forward in medicine, we need to focus on these 6 particular aims: safety. I think safety is self-explanatory. We all want safe care for our children. A patient-centeredness to the care, that was really a revolutionary concept, meaning the care is not centered from the eyes and perspective of the healthcare team, but really from the eyes and perspective of the patient themselves. Working on the efficiency of care, how effectively that care is delivered, the timeliness of the care, whether you receive the acute appointment today, whether you can get the surgery at a time that makes sense for you and your family, or whether you can receive the urgent care needs that you may run across. And then importantly, it was also discussing that really care needs to be delivered equally across the population. Many of you, through your own chapters, know the providers in your hospital really well and probably have some emails and phone numbers that you can use to modify the care of your own child. But I would argue that not everybody has those opportunities, and so really we need to make sure that we're delivering equitable care to everybody. A few years later, a few more tenets were added by the Institute of Medicine, and access was one of them, so access to care. So whether you live in Orlando or Cincinnati or Arizona or South Dakota, your care to excellent care needs to be the same. And then care coordination. So the care coordination that's involved in discharge from the hospital, admission to the hospital. Many of you, as was highlighted in the last talk, your children have multiple health system needs, whether it's kidneys or heart, lung, whatever. How do you ensure that the care that you're receiving is coordinated between all of those arenas? So that's the challenge that's been put to us. Well, how has the medical field responded to that challenge? So this is just from last week. The New York Times looked at how we treat heart attacks in this country. And this slide obviously belongs next door, almost more than it belongs here. But what it shows us is that in the last decade and a half, since that 2001 statement, mortality from heart attacks have gone down 40%. And morbidity from heart attacks has gone down even more steeply. And that's without truly any brand new miracle innovations or any new wonder drugs. It is actually just from the delivery of care in a way that follows those tenets we just saw. It's ensuring that best practices are practiced at every hospital. It's ensuring that everybody has equal access to that care. That's really the driver behind what is termed quality improvement. Now, many of you in this room that have been involved in NPC QIC and Sisters by Heart understand this quality improvement methodology to improving healthcare. NPC QIC is a fantastic example of parent-driven and parent-sustained quality improvement efforts within a national collaborative. And I think this data is correct. It's at 56 sites across 31 states. And the NPC QIC groups have had tremendous success and have had a tremendous academic success and have published many papers, starting with this one about just explaining what NPC QIC was to become the National Pediatric Cardiology Quality Improvement Collaborative, lessons and development from the early years. And those manuscripts have come across and continue to grow, and most recently, now we're looking at improvement in interstage survival in a national pediatric cardiology learning network. So that is, they have begun to use those tenets of quality improvement and have seen a lot of early success in really just a few short years. This is pulled directly from their website, and it begins to talk about the progress that they've had over the last few years. You can see the increase in survival with regards to increases in growth. But one area I want you to focus on is the part in the yellow box that talks about the parent partners, that 50% of the NPC QIC leadership is parents, and that 32% of those projects are engaging parents directly in quality improvement efforts. I think that's remarkable and is a remarkable success. I think the 32% could probably be higher, right? So that's one fantastic success nationally. But not everybody has an NPC QIC site at their in their local chapter or where they live. And in addition, not everybody has an interstage patient. So what are your QI opportunities, your quality improvement opportunities, if you don't have a child who's in interstage and you can begin to work with NPC QIC? What if your CHD interests in particular don't fall outside the scope of some of these national programs? And what if your hospital doesn't have a clear path to parent-driven change? What are your options? What I would argue that quality improvement knowledge is really the currency for change. You, as parents, beginning to acquire that quality improvement knowledge, that is the avenue into making some of that positive change that you and we would like to see. So I'll go back to this picture and this wonderful group of heart kids that I spent last week with. What are the opportunities as parents to positively impact these kids? Well, they told us themselves. So we have several panels in the evenings where we ask them to talk a little bit about their condition and some of their experiences. And they do so very freely. And it's interesting what you hear because they're speaking without their parents or anyone else in the room. And you hear examples of how they talk about their parents advocating for them. They are all so grateful to what their parents have done as advocates for them personally. And what's interesting is one of the kids talks about how his dad, when he was really young, he remembers saying to the hospital staff, "You get one IV stick. That's it. One attempt per person. If you don't get it the first time, call somebody else." I think that resonates with a lot of you, right? So that parent was taking that opportunity to improve the quality of care for their child. But in truth, that parent really had an opportunity to extend that focus onto all children. Not every child has the benefit of that advocate behind them, and then looking directly in the eye of the provider and saying, "You just have one IV stick." You'll hear about transition programs. The kids talk about that. How do you begin to build that transition program? How do you ensure that your child matures into the adult who receives the excellent care that they've received all throughout their childhood? And how do you, another child brought up anxiety management and their parent really helping them cope with their anxiety issues by just doing all the legwork that all of you guys do every day to ensure you receive excellent care for your child. But how do we begin to take that and expand it to the larger population? Well, that's where the model for quality improvement comes into play. So I imagine that most of you can think of something rather quickly that you would like to improve about your child's care. Now, really, up until the last 10, 15 years, we've had two methods. There's the trial and error method, where we sort of blindly go forward and we see what happens. It's very quick, but obviously it's risky to focus on trial and error as a way to improve things that are as important as congenital heart disease care. So then there's also the opportunity for traditional research, and many of you have participated in traditional forms of research, and that is the thorough, time-tested way to improve care. But as many of you have probably noticed, it's really slow. So what if we begin to combine both of these? What if we begin to combine our efforts into a trial and learning methodology? So we trial and we learn, and we trial and we learn, and it's cyclical and it's iterative. We continue to get better. That promises to deliver knowledge with the potential to further improve it. And the truth is that all of you actually have opportunities to begin to enter some of these conversations. So we start with three fundamental questions when we work on quality improvement efforts. And really what we'll be talking about from here on out is giving you guys some tools to begin to think about quality improvement as a place where you can begin to invest some energy. So goal number one when we start a quality improvement effort is, what are you trying to accomplish? What is your purpose and what is your goal? That seems rather simplistic, but actually it's easy to say, I would like my child to have better school scores. But that's a wonderful statement and we all would like that. But what is exactly you want to improve? You have to begin to get very specific. How will you know that a change is an improvement? So you can make a change, but how do you know that actually things got better? How do you begin to measure things accurately and define your outcome? And what changes can we make that will result in an improvement? What are our action items? So what I'll share with you is some of the methodology that we use in Cincinnati. It's not the only methodology available, but given a lot of Cincinnati children's history, it's actually used extensively across the nation, and I'm sure that in most of your local heart centers and heart institutes and such, they're quite familiar with some of this methodology. So it begins by developing a SMART aim. The SMART aim is the purpose of your study. How do you do that? Well, you make a very specific aim, clearly stated. It has to be measurable. It has to be actionable. We can't begin to affect change if it's something that's outside of our control. It has to be relevant, so aligned with the organizational priorities, and it has to be time-bound. This is, for me, one of those slides where you have something that matters deeply to you in your chapter, and you would like your Heart Institute or Heart Center to work on that. Try to bring it to your leadership, focusing on these aims. This will resonate with them so that they all of a sudden will take it and will, at that point, be able to partner with you effectively. And then when you're talking about the measurement, be very specific. While all improvement requires a change, all change is not an improvement. Determining measures allows you to learn if your change is moving towards your target or away from it. Make sure they're specific and numeric and clear. And when we're working on this, pursue usefulness, not perfection. If we are stuck in trying to find perfection in quality improvement, we wait too long to make a change, and every few years that go by where things aren't getting better, we are simply stuck in the mud. There's some specific elements to using this. This is really very Cincinnati focused, but just to give you some idea of how we begin to do this is we look at the SMART aim on the left of the screen, and we look at interventions to get us from what we want to do to delivering on that SMART aim. And we then work through what we call key drivers. So these are the what. What is it that we want to do? The interventions are how we're going to do it, but the key drivers are what is it we want to do? And we speak very much in the affirmative. We want to increase effective communication between parents and their providers outside of clinic time. Or we want to effectively give medications reliably to our patient population without error. And you can imagine the project, obviously the key drivers change for each one of those. Then we begin the process is how do we actually test and work towards that? So we work through what are called PDSAs, or Plan, Do, Study, Act. And so this is how we begin to organize these quality improvement efforts. So we begin with small tests of change. We test this idea, and then we learn from it, and this is that trial and learning approach. And then we try it again. It is not a single step. It is meant to be iterative over and over and over. And the key part of this is that this is what's happening in all of your hospitals today, and if you're not directly involved in it, it's happening without parent input. So they are testing changes all the time. Every time you see something new that comes across your charter's sort of email or however you communicate with your hospital leadership group, everything that's been changed to the hospital is coming through this kind of methodology. And if they're not including you as parents, then we are missing an opportunity for that patient-centeredness approach to medicine. Just to expand a little bit more on what each one of these definitions are so that you can have the language and speak to your providers. The first step is the planning phase. So the first step of the PDSA cycle. And in this step, you create the action plan for change or test by answering the questions of who, what, when, and where. The second step is the doing. So do carries out the plan. This is what we're going to try. This is when you perform that first small test. You would test your change, and you begin to record the observations, and this is where you have to be really thoughtful about your measurement. And any test is temporary, and then we test it again. And how do we know when to test it again? It's because we've studied that first test. So the third step of this is the study. It's time to bring the team that you create to work on this. None of this is done individually, and as I'm advocating, hopefully always done with parents. And you evaluate the results and you determine the improvement. And then you get to the fourth step. How do you act based on that first test? Do you adapt it, meaning we learned something, we got closer to our target, but then we need to do something else, so we're going to test again in a new way, or we're going to test on a new population, or we're going to test on a new time of day, or we're going to test with new people. Or maybe your first test or your most recent test was perfect and it delivered on what you wanted to improve, so then you adopt it. And if you struck out miserably, then you abandon it. But the point of this is that it's not trial and error, because the abandon step is a critical step because you've learned from it, you've recorded it, and it's not just somebody's speculation that something has not gone well. So how does this look? How does this look in reality as opposed to sort of in abstract form? So this is an example of a parent-driven QI project that exists currently in Cincinnati Children's. I'll call attention to Jessica Vila, who's here today from our Mended Little Hearts chapter and our family advisory group. So to give you a little background, and I suspect we're not the only group that struggles with this, parents told us in our family advisory groups that when they left the hospital, they felt like they can get in touch with their cardiologist, but they felt like they could not get in touch with anybody who had anything to do with their feeding regimen. So any of you who've left the hospital with children who have complicated feeding, whether it's G-tubes or NG tubes or just a specific feeding regimen, our parents told us that every day people used to round on us and we would make tweaks together and we'd pay attention to what the feeding tolerance was like. Were we vomiting or not vomiting or pain or whatnot. And then they left the hospital and they said, well, now we feel all alone. This was coming from the parents. In truth, we as providers didn't have any real idea that we were sort of dropping families off at the curb in terms of feeding. So this is not a quality improvement effort that the providers, whether it's nurses or physicians, would have started with. But because we listened to our parents, this is where the parents said, absolutely, this is where we want to start. So the team got a name, Grow Baby Grow. We have some sponsors and team members include all the people you would want involved, nurses, dietitians, and then another parent. And then I serve as the coach for this team. And if you think we started with a softball because we thought, well, okay, this is the first time we've ever had a purely parent-driven QI project. Let's start with something really easy. This is what the process looks like. So it took us a while to arrive at this, but again, this is the process as reflected by parent experience. This map doesn't exist without your voice. So if your providers are attempting to improve things without your voice, half of these steps are not accurate. And so if we make changes, we may not see the effect that we would like. The details of this, I'm happy to share with you afterwards, but are less important. So this project has really just kicked off this late spring and early summer. And so now we're beginning to fill in our key driver, and we're beginning to now fill in what our interventions are. And this is all with the aim of improving weight gain in CHD patients while reducing parental and patient stress. Well, you may think, well, this is all great. I could certainly try to bring this to my leadership, but what about the cost? Well, actually, there's a lot of good news around the cost. Because of that Institute of Medicine statement from 2001 that I highlighted earlier, there are many organizations that are very focused on only supporting research that has parent voices in the research. The most famous of that is a group called the Patient-Centered Outcomes Research Institute, or PCORI is how it's shortened. And this is a national organization delivering on millions of dollars worth of research efforts per site to improve healthcare, not just within congenital heart disease, but across all pediatric conditions. And the key element of this research is you do not get off the ground unless you have equal parent voice in your research efforts. So this is not a cardiologist or a pulmonologist or a pediatrician's great idea. This is largely parents partnering, or the healthcare system partnering with parents to come up with patient-centered quality improvement efforts. The statement from PCORI reads, unfortunately, traditional medical research, for all the remarkable advances in care it produces, hasn't been able to answer many of the questions that patients and their clinicians face daily. And even when reliable information does exist, it's not always available to patients or those who care for them in ways that they can understand or use most effectively. To give you an example of this is not the only one. There's more funding that comes from the U.S. Department of Health and Human Services. There's a branch of that, Health Resources and Services and Administration, that again delivers millions of dollars in grant funding that is dependent on a parent voice being part of that funding. Just to give an example of local funding sources in Cincinnati, we have the Children's Heart Association of Cincinnati, which is a major driver behind NPC QIC, but they also continue to support parent-driven research efforts and in large part, these are mostly QI efforts. And then, in fact, Cincinnati Children's has its own award called the PLACE Award, which is the PLACE Outcomes Research Award, which again, you cannot get any project off the ground unless you have a parent directly involved. This is not just unique to Cincinnati. You can see the emails there, or the website there at the bottom. I guarantee you at each of your centers, something like this exists because that is the movement of medicine today. And this group here within congenital heart disease, you guys are the leaders of this movement. So we want to lead the charge for quality improvement in healthcare. And I would argue that we, along with the healthcare system, we want parents to help us lead this charge for quality improvement in healthcare. Once you guys begin to build that currency of knowledge for quality improvement efforts, it will readily come to you. And it depends on the day. You can ask Jessica if it's fun, not fun, a lot of work. I think rewarding probably is the right word, right? And well worth the effort. So just in summary, what I would say is quality improvement aims towards better outcomes, experience, and value. Only with direct parental and patient, as for patients like Megan and adult patients and teenage patients, only with the involvement can these targets be properly identified, measured, and achieved. Thank you very much.